management of the diabetes with insulin in India. So the role of the insulin in our Indian perspective. So the burden of the diabetes in India is increasing. You all know that the numbers are very high. Nearly 13 crores are the diabetics, and the prevalence is also increasing. And the most important factor for the increased incidence of the diabetes in India is high BMI. So overweight or the obesity and the dietary risk, tobacco, sedentary lifestyles, and alcohol usage. See, according to the 2022 ICMR India study, the poor glycemic control seen across both urban as well as the rural India, despite the availability of the newer oral anti-diabetic drugs. So now we have a lot of the oral anti-diabetic drugs, from the gliptins to the SGLT inhibitors and the newer glimepiride, etc. But still, the control of the diabetes is very poor. At the bottom of the slide, you can say that 64% of the Indian type 2 diabetic patients, they do not attain the A1C target of less than 7%. So our target of HbA1c is 6.5 most of the individuals. Even at the 7, we are not getting even in about 65% of the population. So a lot to be done in spite of our extensive OADs. So I have to still control the blood sugars very effectively. So you all know that diabetes is a dynamic disease, it's a progressive disease, and it is an aggressive disease. And we start with the diet and exercise in the initial few days or a few months, and then we start the metformin, and then we go for the combination drugs like the different metformin plus SGLT inhibitors or metformin plus the gliptin or your glimepiride, etc. And finally, we also need the insulin for most of the diabetic individuals. And you all know that the glycemic control is very important. If you control the blood sugar very effectively, even 1% drop in the HbA1c can reduce a lot of the diabetes complications, both microvascular and the macrovascular, to the tune of about 12% to the 42% of the different complications. So the deaths related to the diabetes, or the heart attacks, or the strokes, or the microvascular disease like retinopathy and nephropathy, all these can be reduced with even 1% drop in your HbA1c. And you all know that the legacy effect as the metabolic memory is nothing but, if you control the diabetes very effectively in the initial days of the diabetes, they will be presenting with the lesser complications at a later time, even though the control is not good afterwards. So the initial days of the diabetes presentation is very important to control the blood sugars very effectively. But unfortunately in the initial days of the diabetes, they don't care for this diabetes because the most common symptom here is asymptomatic. So most of the type 2 diabetes are asymptomatic. They don't listen our doctor's words in the initial days of the diabetics. Once they get the complications, then they will be aware of all these drugs. So that is the reason for our more and more complications of Indian population. So I told you that insulin is very important for the medication of the diabetic individuals. Even at the time of the diagnosis itself, you need to start the insulin when the fasting is more than 250, PP is more than 300, and A1C is more than 9%. So you combine these three, we consider them as the glucose toxicity. So like your organophosphorus poisoning, etc., you have some antidotes. In the same way, in the glucose toxicity, you have the antidote in the name of insulin. So you have to start the insulin once the fasting and the PP and the A1C is beyond these levels, even at the time of the diagnosis itself. Or if the patient has a systemic infection like sepsis, so we need to start the insulin on the day 1. And acute myocardial infarction or any ICU admissions like acute myocardial infarction or CVA or peripheral vascular disease, etc. Or in diabetic ketoacidosis, because it's an emergency, it's a medical complication, it's an acute medical complication, so we have to treat with the insulin only. In pregnancy, especially in the first half of the pregnancy, we always treat with the insulin. Whereas the second half of the pregnancy, you can try with the diet or exercise or with the metformin for some days. But first half of the pregnancy, on the day 1, we have to start the insulin to avoid the congenital malformations. And perioperative care. So if the patient is posted for any surgery, so definitely obviously any major surgery, we need euglycemia. So that's why we have to use the insulin. So, and the most important, all these things you all know that, but most important of is the OAD failure. But unfortunately, you don't recognize the OAD failure in most of our diabetic individuals. That is the reason we keep on using the OHS of the different drugs. So some of the people they take 5 tablets or 6 tablets or 7 tablets, only OHS. In spite of that, the blood sugars are very high. So here the condition is OAD failure. when you consider OAD failure, the definition of the OAD failure is when the fasting is more than 150, postprandial is more than 200, HbA1c is more than 8.5%, despite receiving the optimal dose of the 2 or the 3 OADs. So when the fellow is getting the 2 or the 3 OHs of the optimum dose, still the blood sugars the fasting is more than 150, postprandial is more than 200, A1C is more than 8.5. So that is a OAD failure. Here it's indication for the insulin. So the boy, so obviously the type 1 diabetes, so you need insulin therapy. But here is a third party. So the care, not the primary decision makers. So these people, the management with the insulin is very, very difficult because we have to keep him alive at least for the 70 years or the 80 years. So the longer duration of the diabetes and longer disease burden, a greater emotional burden, ongoing growth and the development. So these are very common in these young children because they are more ketosis prone. They need insulin for more stringent. So we have to be very careful with these children when you are using the insulin of the different dosages. In the same way, the woman is also about the 50% of the population of the women. So the woman diabetes is totally different from the male diabetes. So there we have to treat them regarding their needs, because most of the postmenopausal women, they are at high risk of getting the vascular events, and the pregnancy and the diabetes is a big topic. So this is the normal insulin, normal situation. So you have the pancreas. So pancreas is producing more and more insulin. That is like the key, and that opens the cells, and obviously the sugar will go into the cell. So you don't find any hyperglycemia. But what happens in the type 1 diabetes? As the pancreas is not secreting the insulin, you lost the key. So once the key is not there, the cell is not open, and so all the blood sugar will be there in the blood only. So then you will get the hyperglycemia. But in the type 2 diabetes, what will happen? So the pancreas will secrete more and more insulin, but this insulin is not opening the cells because of insulin resistance. So this resistance is because of your faulty food habits, because of your high saturated fat, because of your overweight, because of the obesity, because of the genetical factors. So this is called insulin resistance or delayed insulin sensitivity. So even though you are having the more and more insulin because of your hyperglycemia, because of your hyperinsulinemia, but still there is hyperglycemia because of the insulin resistance. So the main factor in the type 2 diabetes management is physical activity and the dietary approach. So without the dietary approach, without the physical activity, you can't open the cell even though you are having the more and more insulin. Then obviously you will be present with the hyperglycemia only. And if you see the insulin molecule, how it is having the two phases of the secretion, phase 1 and the phase 2. Phase 1 is the acute secretion. See, we are all now assembled here. The dinner is not yet ready. We have to wait for about half an hour or 1 hour for the dinner, and our pancreas is producing a lot of the insulin. So this insulin is there, and once we touches the plate, and immediately the first secretion, first phase will start. What are all the formed insulin is there, that will be released, and obviously that will control your postprandial hyperglycemia. See what will happen in the type 2 diabetes in the second part. So there is not peak, that the first phase of the insulin is lost. So the insulin is not there. So obviously once you touches the plate, obviously the blood sugars will go up because the first phase of the insulin function is lost, and even the second phase is also plummeted. So this is the physiology of a diabetic individual. Because of the lack of that first phase of the insulin secretion, you are getting more and more hyperglycemia. So this is a very important slide, shows you that any person who gets the diabetes, that means 50% of the pancreas is lost. So till the 50% of the pancreas function is lost, they won't get the hyperglycemia, because remaining the 50% of the pancreas will secrete more and more insulin. So that is called hyperinsulinemia. So after that, again I am telling you that this is a dynamic disease. Every year the pancreatic function will deteriorate by about 3 to 5%. So after the 10 years or after 15 years or after 20 years of the diabetic life, almost all the people will behave like a type 1 diabetes, because even though they are having the pancreas, even though they are secreting the insulin, not of much use because of the beta cell fatigue or apoptosis. See, as the duration of the diabetes is increasing, so the beta cell functional mass is decreasing. So obviously they need insulin at a later time. So the insulin is a very useful drug. It's a glucose lowering, neuroprotective, cardioprotective, and vasodilation and the platelet inhibition. Beta cell gives it rest to the beta cells, so that improves the beta cell function. It is anti-thrombotic, antioxidant, and anti-inflammatory. So a lot of the benefits are there to the insulin in all the diabetic individuals. Those who are on the insulin therapy, let them continue the insulin unless otherwise contraindicated, so that they will have all these benefits. So the big thanks to the orthopedic surgeon and the medical student, the Banting and the Best, who invented the insulin way back in 1921, and they got the Nobel Prize next year. And till 1955, so the no drug is available for both the type 1 and the type 2 diabetes. So they were on insulin therapy only till the 55, and after that, so we got the metformin, we got the chlorpropamide, that is the brother of your dianyl, so those were the two earlier drugs available from 55 to till 80 and 85, and later we have a lot of the drugs in the last 2 decades and the 3 decades. We have seen most of the diabetic drugs. Now the diabetic life is so good. Right now, if the patient can afford, we have almost all the OHS and also the different designer insulins to keep the as glycemic as possible, provided if you listen your words. So the current Indian scenario in insulin usage in the type 2 diabetes. At the bottom of this first half of the slide, in recently published ICMR India 3, only 11% of the Indians were on insulin. See, insulin is a mostly underutilized drug in Indian population. So all the diabetics, they don't prefer the insulin for several reasons. But unfortunately, they need insulin, but they are not getting the insulin. So that is the reason our cardiologists, our nephrologists, and all other specialists are doing extremely well in their own practice because of uncontrolled diabetes, because of their late initiation of the insulin. See the slide here. So the dysglycemic legacy. So you have the two types of the people here. Those people who are on good control, those are on poor control. Suppose if you give the insulin therapy, if you control the HbA1c at, you keep the HbA1c at less than the 7%, so obviously the complications will be less than. So in the second half of the slide, they say that the risk of the cardiovascular disease, that means either heart or the brain or the peripheral vessels, is shown for the patients that HbA1c constantly above 7%. But 90% of our population A1C is above 7%. In the last 2 years, following the diagnosis, for whom the treatment intensification is delayed by at least 1 year versus that of the patients with HbA1c constantly below 7% in the same period. That means those people whose HbA1c beyond 7% more than the 2 years, they are at risk of the cardiovascular disease. That's what is happening in our Indian population. What the guidelines says, whether American Diabetic Association or American Association of the Clinical Endocrinology or International Diabetic Federation, all they say that the differences in implementing these guidelines in the Indian population. So how India is different from the other guidelines? We have our own RSCD, the Research Society for the Study of Diabetes in India, 2022 recommendations, initiate the basal insulin. That is a very easy to start the insulin. And most of our people, they need the premixed insulin also, or co-formulations, and then the premixed insulin either alone or in the combination, and we have to titrate it. So self titration, suppose if you are using the basal insulin, so titrate with the fasting blood sugar. If you are using the BD insulin or premixed insulin, so before fasting insulin and the before 10 blood sugars. So these are the intensification. Accordingly, you have to increase the insulin. See, the type 2 diabetes treatment efficacy, insulin is very effective. So if you see all the drugs I am giving you, so they reduce the HbA1c from 0.5% to maximum 2%. So the only one which controls your blood sugar beyond 2% of your HbA1c is the lifestyle methods. So your diet and exercise or yoga, meditation, so definitely much better than all the drugs in reducing HbA1c. And beyond the lifestyle, the only one drug which reduces HbA1c of any food is your insulin. So it can reduce the HbA1c from 5%, 6%, 8%, 10%, etc. So sometimes I see the patient with HbA1c 16%, 17%, 18%. Your target is 6.5. So that means he is living with the HbA1c hike of about 10 or 12%. So we have to reduce those 16 or the 15% of the HbA1c to 6.5 or 7 only with the use of the insulin. So insulin at the current crossroads, where is it? See, these are the spikes. You have the 3 spikes, that is the breakfast, lunch, and the dinner. And the bottom one is the basal phase. So the basal hyperglycemia and mealtime hyperglycemia, these two are there in the type 2 diabetes. To control these mealtime hyperglycemias with your regular insulin or control the basal hyperglycemia with the basal insulin. That is very easy to say. So that means you have to give the 4 shots a day. So 1 shot at the bedtime to control the basal hyperglycemia and the 3 shots of the regular insulin before breakfast, before lunch, before dinner to reduce the mealtime hyperglycemia. It is very easy to say, but very, very difficult in our clinical practice to use 4 insulins a day. So that is the reason we use the premixed insulins, which are the combination of these two. So we can do the 2 shots. So this is the traditional way. We start with the single drug, then we wait for some time. Again the blood sugars will go up. Then we give the 2 drugs. Again we wait for some time. Then the blood sugars will go up. We give 3 or 4, etc. That is the traditional way. But now the common concept is the combination therapy from the day 1. Or if the patient requires the insulin, as I told you, the indications for the insulin earlier. So if you start the insulin earlier, so that we can keep the HbA1c at the normal levels. So insulin sensitivity and the PPG. See, our Indian diabetic is totally different from the Western population because we are having abdominal adiposity. So the central adiposity, the visceral adiposity is more important. And then the gradual insulin resistance. For a given BMI, we are having the more insulin resistance when compared to the Caucasian. That is the reason the Western population normal BMI is 25, whereas for Indians it is 23. Early decline in the beta cell function. Our people, the beta cell function decline is so early. That is the reason there is a role of the sulfonylureas in our Indian population. Because sulfonylureas, they stimulate the beta cells to release more and more insulin. And increase in cardiovascular risk. A lot of the people, they are getting the cardiac problems even at the age of 25 or 30 because of the early onset of the diabetes. And higher risk of the microvascular complaint like retinopathy and the nephropathy. So in this way, we are totally different. See these 2 graphs. The left one, the change in the plasma insulin. The red one is our Indians and the blue one is the Caucasians. See the insulin. So we are having the little more insulin when compared to the Caucasians. But see the blood sugars in the second graph. The blood sugars are very high when compared to the Indians, when compared to the Caucasians. That clearly shows that even though we are producing more insulin when compared to the Caucasians, this insulin, more insulin, supposed to reduce the blood sugars, but still our blood sugars are much higher when compared to the Caucasians. In the same way, the contribution of the PPG to the HbA1c. So our population, the HbA1, the fasting and the postprandial blood sugars, if you see, even when the HbA1c is at a lower level, say I am saying the target of 7 or 6.5. Suppose the target is 7 or 7.5 or 8. So here the fasting blood sugar role is much higher when compared to the postprandial. Whereas if you see the Asian individuals, at any given of the HbA1c, postprandial blood sugar is much important than the fasting blood sugar. So especially our Godavari district, most of the time 18 hours we are on the either postprandial or absorptive stage rather than the fasting. So the true fasting for all of these is hardly 4 hours or the 5 hours. So that is the reason postprandial blood sugar control is much more important in our population when compared to the fasting hyperglycemia. You can control fasting hyperglycemia very easily with your basal insulin. But we are having the more of both the fasting as well as the postprandial hyperglycemia, which will not be controlled with the basal insulin alone. So that is the role of the premixed insulins here to control both fasting and the postprandial. See higher postprandial glucose excursions in the Indian population. See the second half. Indian patients show higher PPG levels, your postprandial glucose levels before the insulin initiation. See the India almost 279 is our average HbA1c, postprandial blood sugar when compared to the Italy 176, Poland 209, Canada 214, Russia 218, Greece 212. At that level they start insulin, but we wait till the 279 of our postprandial to start insulin, which is very bad. See the PPG excursions in the type 2 diabetes. See the plasma insulins in the normal subjects, the type 2 diabetes. So the normal subject is the dark one, and the blue one is your diabetic individuals. So the PPG excursions, plasma insulin, plasma glucagon, hepatic glucose production, and then the plasma glucose. So the loss of the early insulin release contributes to the PPG excursions in type 2 diabetes. So the PPG profile is written by the 3 processes. One is your diet. Most important is our diet. So the diet plays a major role in increasing your postprandial blood sugars. And of course, the liver also plays a major role because hepatic glucose production is more and also the muscle and adipose tissue because of the less entry of the glucose here because of insulin resistance. So need of the insulin Indian patients, the carbohydrate content in the diet of the Indian patients is very high. So we need the postprandial control much better, much important than the other population. So why to choose a premix insulin? So coverage of both fasting as well as PPG, effective HbA1c control, improved PPG control, a single device, fewer injections, lesser dosing errors, and it is convenient and option to intensify the same insulin. See, this is good for most of our population. Suppose the patient is very educated and very compliant, so then you can control with the basal insulin and the prandial insulins in those individuals. So criteria for the patient selection, the premix insulins, so glycemic status, duration of the diabetes, associated acute comorbidity, lifestyles, patient preferences, these are all plays a major role in selecting these premix insulin. So the insulin therapy is both art and the science, like medical practice, but there are a lot of the barriers to the insulin. See, the fear of weight gain as per the patient point of view, permanent need for the insulin therapy, once on insulin, lifelong insulin, fear of hypoglycemia, fear of injections, feeling of the failure, less flexibility. So these are some of the factors for the insulin distress among the patients. In the same way, there are some barriers from the physician's point of view. But I don't think that Kakinada doctors are having any barriers for the insulin therapy. So we are all good in insulin therapy. And the role of motivation is very important. See, the proportion of the patient adhering to the treatment is significant after the counseling. So, with the good counseling, with expressing the empathy, rolling with the resistance, developing the discrepancy, supporting self-efficiency. So, definitely, most of our people they listen for our insulin therapy. But how to recognize the inadequacy of the oral therapy? This is the very important slide. At diagnosis, there is more than 50% loss in the beta cell function. Yearly, there is a reduction in the cell counts. So, this is seen with 2 OADs used maximally. Increase the hyperglycemic symptoms of weight. This is a very important take-home point. Any diabetic who is symptomatic, who is dehydrated, that means there is a role of insulin in them. So that means their catabolism is very high. You have to use the anabolic hormone like insulin in those individuals. So when the fellow is losing the weight, when the fellow is having the polyuria, when the fellow is having the nocturia, when the fellow is having the polydipsia, so definitely there is a need for the insulin in those type 2 diabetic individuals, even though they are 2 or 3 or 4 OHs with high HbA1c. So the PPG, this is the, I told you several times, the need to fix the fasting first with the basal insulin. So this is the dosages to use the basal insulins. And the patient is not at the goal, the next step should be a postprandial blood sugar correction also. So is the postprandial blood sugar is harmful? Yes. Bottom line, so this slide is not showing you much better. There is a post-meal hyperglycemia is harmful and should be avoided. So postprandial means, is it 1 hour? Is it 1.5 hour? Is it 2 hours? So this is again a million-dollar question. But earlier concept is always postprandial is 2 hours, but now the concept is 1 hour. 1 hour PPG. See, the postprandial blood glucose is a stronger predictor of the cardiovascular events than the fasting blood glucose in type 2 diabetes, particularly in the women. See, 1 hour PPG might be more dangerous than the 2 hours PPG simply because of the glycemia is higher at the first hour. So, the targeting 1 hour post-meal glucose is the time for a paradigm shift in the diabetes management. So, if any of your patient gets the 1 hour postprandial, don't scold them. So why don't you wait for 1.5 hours, 2 hours to get the correct PPG? So he's right, you are wrong. So even you accept the 1 hour PPG also as a postprandial blood sugar levels. So why 1 hour postprandial glycemia might be dangerous? Because even the 1 hour postprandial hyperglycemia, there is increased arterial stiffness, increased LV mass, LV diastolic dysfunction, endothelial dysfunction, and higher triglycerides, apolipoprotein B levels, etc. So high 1 hour PPG exhibits significantly worse cardiometabolic profile, predicts significantly higher mortality when the 2 hour PPG is the norm. So I will stop here with this one case. She is about 49-year-old female, a corporate employee. Diabetes duration is 9 years. Food habits, two major meals, one snack, mid afternoon. This is the very important. Whenever you say diabetic, please ask the food habits. You are asking the duration of the diabetes, family history, smoking, alcohol, etc., etc. But most important question you are supposed to ask is the food habits. So some people they take the brunch, some people they skip the lunch, some people they take the heavy dinner. So accordingly, you have to adjust the dosages of the insulin or the OHS. So recent body weight change, that is also very important. Suppose recent loss of the weight, so definitely there is indication for the insulin therapy. Recently body weight increase, so don't use the insulin. Use the SGLT inhibitors or use the GLP-1 receptor agonists, etc. No history of the hypoglycemic events or recurrent urogenetic infections. Medications, glimepiride she is getting 2 milligrams, metformin 850 milligrams BD and cetabine. So she is getting 3 tablets, 3 drugs. One gliptin, one metformin and one sulfonylureas. Now the weight is 71 kgs, height is 168, so the BMI 25. Sore on the right foot, little toe, so that means diabetic foot ulcer. Reduce sensation to the monofilament testing. So already neuropathy is there. Fasting is 180, postprandial is 248, A1 is 9%. Creatinine is 1.1. Is a corporate employee, simple, and is to use the insulin therapy is desired. So what is your HbA1c target for this patient? So obviously 6.5%. So what is your primary goals? Reduce HbA1c? Yes. Avoid hypoglycemic events? Yes. Always avoid the hypoglycemia because if the patient gets the severe hypoglycemia, it is almost equal to the death. So definitely they don't come to you again and again. So we have to avoid the hypoglycemia, especially in elderly individuals. Optimal weight maintenance is very important and prevent the further foot complaints because already she got diabetes nephropathy, neuropathy and the foot ulcer. So amputation is very, very common in those individuals. So avoid do good foot care. Also all of the above is important. See, this is the durable initiation. So insulin glargine versus the lispro mix. So they are presented with the glucid rapid and the glucid mix. So this is a very good combination. So by using these mix combinations, so definitely you can see the lispro mix 25 therapy was found to be non-inferior to the glargine and the lispro therapy for the end of the study. So back to the patient, we have started it on, and the response is so good. So at the 3 months follow-up, patient maintained the premix insulin twice daily with HbA1c 7.1%. Weight has reduced to 74 kgs and foot ulcer also healed. So I stop here. So this is my conclusion saying that insulin is the most appropriate drug in our diabetic individuals. So please see the indication for the insulin therapy and start accordingly. So when you are in a doubt, when you want to start the insulin the first step, continue the same OHS in that particular person, start the basal insulin. Suppose if the A1C is very high, if the patient is having some complication, so definitely have to switch over to the mixed insulins like a glucid mix and treat both fasting and the postprandial hyperglycemia very effectively. And please listen to the patient about their food habits and then act accordingly. So thank you very much for your patience.